Harris. I'm the Assistant Director for Policy and External Affairs at the McSilver Institute for Poverty Policy and Research, and a member of the CTAC and MCTAC teams. We're pleased to be hosting such a timely presentation today on New York State's draft 1115 waiver. I'll be keeping my piece particularly brief today, and just really quickly running through the presenters and just a minute or two of housekeeping. So as folks continue to get settled in, please bear with me. So we've got a great roster of presenters today, in addition to, I'm sure, additional folks on the state's end available to help out with the Q&A. But leading us through the presentation for today are Caitlin Kennedy with the Department of Health, Mimi Weber from OCFS, and Meredith Ray-Labatt and Barry Kinlan from OMH. So welcome and thank you to our presenters. Before we hand things over to Caitlin to kick things off, just a quick housekeeping note. So the slides are already posted at ctacny.org. If you go to upcoming events and look on the calendar, there'll be a link posted there. The recording, per the usual, will be made available in the next day or two and will be included in next week's weekly TAC Digest. Also, while you're on the CTAC website, we'd suggest folks take a look at some of the past events that might be relevant to the topics of today. There's the November offerings around children's behavioral health, HCBS, and then going back to July, walkthroughs of the SPA services. So moving on, we encourage questions to come throughout. We've got a great team of folks on the state side who will be fielding questions today. So it gives them a chance to kind of get organized before we launch right into Q&A. If you can send those in. To use the chat feature, you click on the chat bubble on the upper right or lower right side of the screen. Our only request is that you please send them to all panelists in the drop-down when you're optioned to send to. We're in geographically different places on the presenter and hosting side. It's just really helpful for us to keep track of things as they come through. And then without further ado, I would just be glad to turn things over to Caitlin Kennedy from the Department of Health.
Good afternoon. Thanks, everyone. So we're going to try and keep this presentation pretty brief so that we can get right into the FAQs. Our agenda for today is to provide some general information on the Medicaid redesign for the children transition. We're going to cover research goals in the 1115, delivery system changes, eligibility, benefits, payment. We're going to get into some additional resources that are available to you all, and then we're going to jump right into FAQs. So, the Children's MRT redesign update. The state does remain committed to moving forward with the children's redesign. The anticipated timeline for implementation will run through January 2019, and that will include transition of the voluntary foster care agencies and children in their custody in January 2019. Depending on the time frames for the approvals that we need to move forward with this process, including the state plan amendments and the approval of the 1115 waiver, we may need to adjust the dates, but the state remains committed to moving forward as quickly as possible. We are continuing to move forward with finalizing the design documents and doing as much implementation work as is efficient given the uncertain time frames. The submission of the 1115 is pending review of the federal administration priorities and processes, and as soon as we have, a little bit more insight into what that's going to look like, we will move forward. 2 SPAs have been submitted to CMS to implement the 6 new SPA services. We have 1 state plan amendment for 5 rehab services and 1 state plan amendment for other licensed practitioners. Those are moving to the state plan. And approval of the state plan amendments and the 1115 waiver continue to be linked. Those are posted on the DOH website. The 1115 document is available for review and has been posted on the DOH website. I hope you guys have all had a chance to start looking at that. Please send all of your comments by March 15th, that's 2 weeks, to bh.transition@health.ny.gov. The Children's Spa and HCBS provider designation application was released on December 21st, 2016. We held a webinar, which is posted online at the CTAC website. You can review that at any time. Those applications should be submitted to the state by April 1st, 2017. This is going to be a rolling review, and we will accept applications on an ongoing basis, but we really encourage providers to submit their designation applications before April 1st so that we can ensure that they are designated and ready to provide services at the cutover date. Companion regulations are also being drafted for SPA and HCBS services. So here we have some upcoming milestones. We have the deadline to submit feedback, March 15th, 2 weeks, on the 1115 waiver. We have the provider designation applications due April 1st, about 1 month from now. We have deadline for submission of feedback on the children's system transition requirements. I encourage you all to take a look at that. That's posted online. Stakeholder feedback is accepted through April 5th. And then we plan to release the final version of that in June. So this slide is showing kind of a general overview of the type of changes that we're making. Not all of these changes are within the 1115. In general, we're making changes to the Medicaid services where we've launched Health Homes for Children. That was December 6, 2016. We have new addiction state plan services, new children's state plan services, and residential supports and services. We have changes affecting Medicaid managed care. Previously exempted and excluded populations will be moving into managed care. That's your kids who have an exemption related to enrollment in the 1915C waiver, and at a later date, the kids in the custody of a voluntary foster care agency. We're going to be moving previously carved out services into the Medicaid managed care benefit. We're going to be phasing these changes in on a regional basis, starting with Westchester, New York City counties, and Nassau and Suffolk counties, then moving to the rest of New York State. And after the rest of New York State, we'll be looking at the foster care transition. We're also moving some SPA services under the 1115 MRT waiver. Some changes that are being moved into the 1115 waiver are transitioning and aligning the HCBS services that have been available under 1915C waivers into the 1115 MRT waiver. We're providing health home care management for all HCBS recipients, and we're including new HCBS populations. So here's an overview of the draft 1115 MRT summary. The state has set several research goals as part of the 1115 waiver to evaluate hypotheses and examine the impacts of demonstrations on access, quality of care, and cost. Goal 1 is to improve the health outcomes for HCBS eligible children and youth under 21. Goal 2 is to improve timely access to EPSDT benefits that address early BH needs and health needs of children for improved health outcomes and long-term financial savings. Goal 3 is to increase access to the uniform HCBS benefit package to improve health outcomes. Goal 4 is to increase access to HCBS and reduce the number of children being referred to more costly institutional level of care. Goal 5, improve access to the integrated health home model for all children and youth to improve coordination of care and increase access. Goal 6 is to improve the integration of care for children and youth exempt or excluded from managed care in the demonstration. And Goal 7 is to improve continuity of care for the youth who transition into the adult Medicaid service system, to the health and recovery plans, and to other mainstream Medicaid managed care benefits. So here we have the delivery systems based on eligibility group. You have kids who are not excluded from enrollment in Medicaid managed care plan or special needs plan. They're going to be receiving their benefits through the Medicaid managed care delivery system. They're going to receive health home care management. The MCO will provide care management to the children who opt out of health home care management. And you also have children who are exempt or excluded from enrollment in a Medicaid managed care plan or a special needs plan. They'll receive their services on a fee-for-service basis. They'll also be eligible for health home care management, or if they opt out of health home care management, will be able to receive care management through a state-designated independent entity. Important to note that non-medical transportation is provided on a fee-for-service basis for all enrollees, whether they're enrolled in managed care or not. Delivery system based on eligibility group. Children and youth who are affected by the demonstration and are already enrolled in Medicaid managed care will not change delivery systems or providers. There's not going to be an impact there if the kid is already enrolled in Medicaid managed care. Children and youth receiving HCBS but not eligible for Medicaid managed care enrollment will remain in fee-for-service until there's a change on their record that requires them to enroll in Medicaid managed care. The current Medicaid managed care and special needs plan enrollment process will continue to be utilized for this transition. Delivery system for care management services. Children receiving HCBS will be enrolled in and receive care management from health homes. Was this somebody else's slide? Sorry.
No,
I just want to make sure. Okay. Children that choose not to enroll in health home care management will receive HCBS and are enrolled in Medicaid managed care. Children that choose not to enroll in health home care management and receive HCBS and are enrolled in Medicaid managed care will receive HCBS care management from the Medicaid managed care plan. Children that choose not to enroll in a health home and receive HCBS also are eligible for care management services, and that will be provided by a state-designated entity if they're not enrolled in a Medicaid managed care plan. Children eligible for HCBS and Medicaid and children who are being evaluated for HCBS and Medicaid eligibility as a family of one will be assessed by a state-designated entity using the same uniform process to determine HCBS Medicaid eligibility that's being used for all of the other kids through the health home process.
All right, thanks, Caitlin. So we're going to dive into some of the components of the 1115 waiver amendment. So first and foremost, we have been working diligently, as many of you know, to align the 5 existing 1915C home and community-based waivers into a single benefit package for kids who currently meet the institutional level of care. And as you all know, that includes children who are medically fragile or have a behavioral health diagnosis or who are in foster care with developmental disability. And so the services from the existing 1915C waivers are going to be combined into a single benefit array. We want to ensure that children and youth with comorbid conditions have access to the same set of services based upon their assessed needs, as opposed to the system in which they receive their services or their care today. Through the 1115 waiver amendment, we will be removing the exemptions and exclusions from Medicaid managed care for the three following populations: children and youth who are currently in receipt of HCBS services, children and youth who are in the care of voluntary foster care agencies. The word custody is inappropriate there. Children are in the custody of the local Department of Social Services. They are in the care of voluntary foster care agencies. So we'll be sure to make that change before this goes out, as well as children and youth in an OASIS residential RRSY setting. So continuing on with some more of the highlights, we're moving to exclude behavioral health services into a Medicaid managed care environment. Health home care coordination, care management services will be available to all children and youth meeting the HCBS eligibility. And one of the most exciting aspects of the redesign is expanding the HCBS eligibility to include a level of need population for children and youth at risk. And I think you've all heard us talk about the distinction between level of care and level of need, and we're going to get into that in a little more in a second. but it is one of the highlights of this entire redesign. A summary of the 1115 waiver amendment in terms of benefit changes. We're incorporating the Medicaid state plan behavioral health services into the Medicaid managed care benefit package. We are going to provide HCBS benefits in the 1115 to the following, including children who are HCBS eligible, children and youth who are exempt or excluded from Medicaid managed care will receive their HCBS services either through and payment will be arranged either through the managed care plan and will continue to be available on a fee-for-service basis. As we said before, we're expanding the HCBS benefit to not only include children who meet the level of care criteria, but to a new category of children who meet the level of need criteria. And that's for our existing Medicaid population. We are expanding Medicaid eligibility and HCBS benefits to children and youth with waived parental income who meet the level of need category. And so that is also a pretty significant highlight and huge advantage for kids and families across New York State. Aligning services. I think you've all heard us say over the years how excited we are to align the services that are currently available through the OMH waiver, the 3 B2H waivers, as well as the DOH care at home waivers into a single benefit package. We think that that has the opportunity to create some consistency, avoid confusion for children and families, as well as service providers, and expand access to services. We are aligning children's HCBS benefits and the administration for a consistent eligibility process. That's a significant advancement that we're really excited to talk about. We all know that in today's environment, the eligibility criteria for the care at home waiver, for the OMH waiver, and the B2H waiver, not only is the process different, but the eligibility requirements vary today. And we're spending a tremendous amount of time right now trying to think through how we can align the process and the eligibility criteria. Health home care management will be available for all HCBS eligible children and youth. And as I think I've said at least 3 times, we will be offering a single benefit package for those who meet the HCBS eligibility criteria. We've also been spending a lot of time talking about what that eligibility criteria is. We know that in order for a child to be HCBS eligible, they're going to have to meet certain targeting criteria, certain risk factors, and certain functional criteria. And that is all laid out in the online document. Once again, there are 2 levels of HCBS acuity or eligibility criteria. There's what we know today, our existing level of care, so children who are otherwise eligible for a hospital, a nursing facility, or an ICF IDD, and were historically and are currently served by our 1915C waivers. And we're expanding to include a new category of eligibility called level of need. And that's based on having functional criteria that places children at risk of institutionalization. And so that group of kids and services will be phased in over a period of time. So I'm going to continue on, and then I'll turn it over. So HCBS eligibility populations. So the children who will continue to meet the level of care criteria under the 1115 demonstration authority includes children who have a diagnosed serious emotional disturbance, children who are children who are medically fragile, or children who are in foster care and meet the OPWDD eligibility for developmental disability. The level of need populations include two distinct groups. They are children who either are seriously emotionally disturbed or have experienced abuse, neglect, and/or maltreatment, or who meet the health home complex trauma definition. And so you can see that we've gone from 3 populations of kids who are able to access HCBS services to an additional, we're expanding that to include 2 additional populations of children. And so moving forward, you'll hear us talk about the 5 populations of HCBS eligible children. I'm going to turn it over to Meredith.
Thank you, Mimi. Hi, everyone. This is Meredith Ray Labatt. I'm from the Office of Mental Health, and I'm going to continue on talking a little bit about HCBS and HCBS eligibility. Within the 1115 waiver amendment, we've outlined a lot about HCBS eligibility. So there's a couple of slides on it. So we're going to go over the specificity of how it's laid out in the document. But in order to really meet HCBS eligibility, you need to qualify in a couple of different ways. So there's the eligibility for based on your HCBS functional criteria, which is, as we just talked about, which is level of care or level of need. So your target criteria is your diagnosis and your population. Your risk factors are your institutional at-risk level of care, or you're at risk of being institutionalized for level of need. And based on those assessments, of course, using the CANS New York, that could enable a child to be eligible for HCBS. There are two ways in which children who have such functional deficits to become eligible, one of which is they're already in Medicaid, so they meet regular Medicaid community rules. And so if they're already in Medicaid and they're assessed and they're determined to meet level of care, level or need, they can access HCBS services. The other eligibility pathway is through what we call family of one. So when the family income can be waived to allow the child or family to be considered a family of one, if they've already met the functional criteria, they can be determined Medicaid eligible through that mechanism as well. So you can, kids who really have these high level of needs can access these services through a multitude of different pathways, and it's all described and outlined in the 1115. Okay, great. So as I just mentioned, the one of which is the CANS, the assessment of the acuity level. So one of the other exciting things that we've done is really try to align, as Mimi described very well, the different ways in which children are identified to be eligible for HCBS. And really, we have tried to align the different tools that are going to be used across the different populations through a uniform assessment tool, so that regardless of your diagnosis, you can be assessed consistently across the populations, so there's not any sort of differentiation of the populations. And those assessments reflect an alignment of, obviously, as I said, the target criteria, which is your diagnosis, your functional deficits, and your risk factors, so that everybody's being, quote unquote, measured on the same elements, on in the same way. So health homes will be responsible for assessing individuals already enrolled in Medicaid. Again, all health home care managers are going to be using the CANS New York tool, and based on the scoring of the CANS on the different domains, children can be determined to be HCBS eligible based on, again, level of care, level of need. And in addition, the state will have a designated independent entity that will be responsible for assessing children who are not currently enrolled in Medicaid in the absence of health homes. So while children who are automatically in health home can get their assessments done right away through the health home care management, children who are going to be identified through the family of one pathway, there will be a state-designated independent entity that will assist in helping to determine HCBS eligibility to assure quick access to services to avoid hospitalizations for those high-need kids. Great. Also in the 1115 amendment, there are a couple of different provisions and a couple of different allowances, one of which is kind of like a recognition of we only have so much money. So that's what this is. First of all, in the 1115, children who meet eligibility at the point of level of care, so they meet institutional criteria and they are eligible for HCBS, there will no longer be slot limitations, no longer be wait lists. So today, speaking from OMH, we have a certain number of slots that we have for children throughout the state for the HCBS waiver. That will not be the case under the 1115. If you meet the eligibility, you can access the services. So for the level of need population, what we've built in is just some different capacity to acknowledge that if certain numbers exceed what we estimated fiscally and numerically in our estimates, exceed what we had planned, we have some capacity to manage those numbers. So if the actual enrollment exceeds the projection, the state can modify our non-financial needs-based eligibility criteria. So we can make modifications to what we've previously outlined in the eligibility criteria for level of need, or we can limit the number of family of one children to the total number that we've projected, so we can maintain our spending within the annual spending cap. So that's also built into the 1115. Right. So in speaking about what our projected numbers are and what we anticipate to be eligible for HCBS in the future, what we have here is a projection. First, it shows you what we actually have in 2014 is the year from which this data is pulled, who is in HCBS services, quote unquote, today, meaning 2014, and then what we project come 2022, long time from now. And so you can see the numbers and the expectations for how many kids would meet eligibility based on the data pulls from the Medicaid data. So we're really expecting to be able to serve a much larger number of kids through this expanded population of eligible kids and who can now access this wonderful array of new aligned services. So, I know. I actually was going to say, you know, we will be posting this PowerPoint in addition to the recording, so you will have time to peruse these more closely at your leisure at a later date. So this won't be the last time you see it. No worries. Okay. So there's a large breadth of benefits that are covered under the 1115 waiver amendment, because as you know, we are using this as a venue for moving our 1915 Cs, where we're acknowledging that there's a new redesign going on, as well as the moving of services. So, you know, on the kids side, it wasn't like, oh, we're just going to move over to managed care. We thought, well, let's do something exciting with it as well and change the system to meet the gaps that we have identified, or address the barriers for what we know impedes access, or add things that we know have really been missing from how the children's service system works. So, because we make things complicated and exciting on the kids' end. So really, we are attempting to accomplish a lot. So we have, obviously, in the service array, we have the new state plan services, and those are available through state plan benefits through any child who's enrolled in a Medicaid managed care plan. We have the demonstration benefits, which are for enrollees also in managed care, the outpatient and residential addiction, the licensed behavioral health practitioner benefit, and crisis intervention benefit. We obviously have the aligned HCBS array, which we've just talked about, which we are requesting authority to provide under this demonstration. And there's also the Community First Choice option, CFCO, which is for Medicaid enrolled children who meet institutional level of care, only LOC kids, and that we're also including the authority to provide CFCO services to children who are family of one and Medicaid eligible based on LOC eligibility only. So there's a lot included in this waiver amendment, and it's really exciting to see the breadth of the changes that it's going to have on the system of care and the additional new access that we're going to provide to children throughout the state. So if you're wondering what is this HCBS that we have been speaking about for a multitude of slides, here they are. So this is the aligned service array that's included under the HCBS. And if you note that previously some of these services have only been available in the Care at Home 1 and 2 waivers. Some of the services that have only been available in the Bridges to Health waivers or the OMH waiver, although I'm not sure that there's only there. But, and we've actually added a couple of services as well that have not previously been accessible under any of the waivers previously. So it's very exciting. So obviously under any HCBS, there's a care coordination component, and that would be provided under Health Home, or obviously, as we spoke about before, an MCO or a independent entity if you're remain in fee-for-service. Habilitation caregiver family supports and services, respite, pre-vocational services, support employment, community self-advocacy training and support. Non-medical transportation is one of the newly added services to the service array, so that's very exciting. I actually saw a question about that on the chat box. Adaptive and assistive equipment, accessibility modifications, palliative care, and again, a newish service, which is we are going to be doing a pilot for customized goods and services, which will include a financial management services component. So what this is if you're familiar with the OMH waiver, we have had flex funds for some time. This is a mechanism for how flex funds can be accessed, similar to flex funds, but with a financial management services overlay. And we're going to be doing a pilot in regards to this service so that we can really test it out and collect some data and get some information about how it would work in this new structure. So we're very excited about that as well.
And Meredith, if I could just add, for the waiver service, the current 1915C home and community-based waiver service providers that are listening in, the service of habilitation is actually inclusive of two of our existing services today, day hab and skill building. So I don't want anybody to feel confused that a service might be missing as they start looking at our existing manual. So just to be clear about that.
Thanks.
Yeah, you're welcome.
I would have put a little parens had I realized that. All right. Oh, just as I was speaking, if those of you who are interested in hearing more about this customized goods and services pilot of I Speak, what I just mentioned, this is just a quick summary of what our plans are. This is we're doing what has already been initiated on the adult HCBS side. There's a pilot going on the adult side, so we're following suit. This is a self-direction pilot that will be available to HCBS eligible children. It is these are services that can be purchased by an individual who is receiving HCBS to meet their person-centered needs, and obviously has to be tied to their plan of care goals. There's going to be no more than 8 pilot sites phased in over the demonstration. The funding should not exceed $2,000 annually per participant, and participation in the pilot is voluntary. And the state will develop a waiting list if necessary. And so obviously, again, this is based on what is being done on the adult side. We're going to continue it and do a similar pilot on the kids side. And now I'm going to turn over to my colleague, Barry Kinlan.
Thank you, Meredith. So just a few more slides and we'll finish up and get to your questions. Another part of the 1115 waiver amendment focuses on payment, and so we'll just cover that quickly here. As part of the 1115 waiver, the state plan services have been added to the Medicaid managed care benefit package, as we've said today, and those will be included in the plan capitated rates, also known as at risk. The Medicaid managed care plans will also be required to pay at least the fee-for-service rate, also known as the government rate, for the first 24 months for the following services and providers. The essential ambulatory mental health and substance use disorder services, which include the OASIS clinics, Article 32 certified programs, the OMH clinics, which are the ambulatory 31 licensed programs, and the residential preventive services for youth. These are the development for the rate for the residential foster care services. As well, the new EPSDT state plan services, the children's home and community-based services, and the community first choice option, which will be delivered outside the state plan benefit package. So 2 other things quickly. The fee schedule for the transition will be developed for the Office of Children and Family Services voluntary foster care agencies for at least 24 months. And care managers transitioning from providing services under a child's 1915C waiver to the health home may also receive a transitional rate. Public notice for the 1115 MRT waiver. On the Health Department's website, you can find a lot of the work that's been done by the MRT Health and Behavioral Health Subcommittee. They've been meeting quarterly since 2014, and this work has really been discussed since way back in 2011. The web link on this slide can take you to a page which has meeting dates and materials. DOH, OASIS, OCFS, and OMH continue to meet regularly with Medicaid managed care plans, provider associations, parents, and constituents regarding the important transition that we're talking about today. And the public notice for this 1115 was made back in September 21st of 2016, and there was a comment period for 30 days. The amendment that we're talking about today does incorporate those changes and suggestions made by the public during that process. And as my colleague from DOH, Caitlin Kennedy, said before, we are accepting more feedback on this waiver up until March 15th. So just because it says a public notice did occur on this slide, it's back out there for feedback. Two other resources that you probably want to take a look at are the State Plan Service SPAs, which are on this web link here. And there are resources on CTAC's website, which include manuals and webinars. And like I think I just said, the 1115 feedback on this waiver can be found, and we're looking for submission by by March 15th to the bh.transition@health.ny.gov, and you can find the official document at the link on this webpage. And our last slide here just gives you some resources about how to stay informed on listservs, email boxes. If you have questions, please feel free to shoot those to the emails on this slide. I think we'll take a look at the chat box now and try and address some questions the rest of the time.
Yeah, and I think there's one question that we can immediately address. Someone has asked if meetings have been scheduled with CMS regarding the 2 state plan amendments. And we can answer affirmatively that yes, there are meetings that are on the books starting next week to talk to CMS about the 2 state plan amendments, which would cover the 6 new services. So with that, I think we'll go on mute for a second and join you back after we look at the other questions that have come in.
Hi, so there was a question, there was a provider who submitted their HCBS SPA application about 2 weeks ago. So they were asking, when should you expect to hear something? Thank you so much for that, by the way, very good. We will start reviewing applications come April 1st. So we will be starting to prioritize who and based on region and based on types of providers who we're going to be reviewing, and then we're going to initiate the process in beginning of April. So we're going to try to do things as quickly as possible, but that's when we're starting our reviews.
And Meredith, another question has come in. Once HCBS waivers folded into the 1115 and the health home care management process, will waiver slots still exist? And the answer to that is no. A huge attribute of moving our existing 1915 Cs into the 1115 waiver amendment is that we're in fact not allowed to have waiver slots. So the slot concept will go away.
So there's a question, when will billing information for the services be released? As you know, we've submitted our SPAs to CMS, and we are waiting to hear back from them before we can provide information on the billing. We will be releasing guidance separately for the SPA services and for the HCBS services, and that should be coming soon.
Thanks, Mary. There is a question of, for family of one with level of care, are you stating you can limit enrollees? So because level of care is an existing population that we serve under the waivers, due to something called maintenance of effort through CMS, we cannot limit enrollees for level of care. There won't be wait lists, there won't be slots for level of care. The limitations that were discussed in the slide deck in regards to working within the annual global cap was really very specific to our newly expanded population of level of need only. So that's the difference between level of care and level of need.
So there's another question that came in. It appears that the state is expecting a significant increase in the number of children to be served. The question is the current delivery system infrastructure able to support the level of increase in the near term in the next few years? And I think, we collectively share the need to develop locally based service providers. And so you'll hear us talk about how it is that we can support our existing network of service providers and how we can continue to expand the network of service providers across the state. That same individual asked if we could provide a rough conversion of the number of member months to the number of children. And if Brenda is on, could we unmute her to answer that question? Brenda, are you able to hear us and respond to how to convert member months to the number of children? Okay. We'll move on.
There was a question from somebody, will children with third-party health insurance continue to be excluded from Medicaid managed care enrollment? Yes, children with third-party health insurance and adults as well will continue to be excluded from Medicaid managed care enrollment.
Right, so that means on the children's side, and part of the redesign does acknowledge that there still will remain a fee-for-service component of these services that children will be able to access through fee-for-service in addition to the Medicaid managed care.
Absolutely. The only changes to exemptions or exclusions are related to the 1915Cs, these 5 1915Cs, and the children in the care of a voluntary foster care agency.
There's a question about, will there be deeming for SPA services? If not, how will HCBS families receive family care support services via the family advocate, psychosocial rehab, and so on and so forth? If a child is determined to be HCBS eligible, they will have access to the full array of Medicaid services, including the state plan amendment services. So only if they meet HCBS eligibility. There will be no family of one without HCBS eligibility.
So we have a question. Another one, since DOH will be removing the exemption from mandatory enrollment, how will DOH require managed care organizations to handle out-of-network providers past the 180-day transition for continuity of care?
So this is Shelley Wiseman from OMH. So we're including a requirement that children can continue to see their providers even if that provider is out of network for 24 months from the date that that child's services are carved into managed care, and that's for an episode of care. So we've actually included a number of provisions in the plan qualifications document that was referenced earlier in this presentation that address continuity of care concerns. So then that was one of them.
So Shelley, the person went on to ask, will we require children to switch providers? And based upon your response, I believe the answer is no. We will not require children to switch providers. They go on to ask if this will create the need for out-of-network agreements.
Right, so it'll be between the plan and the provider to determine how to pay for those services, whether it's a single case agreement or otherwise, depending on how many children are enrolled with that provider and that plan. So the idea is that children will be able to continue seeing their providers from their perspective of the person that's enrolled in Medicaid managed care. Nothing should change for that episode of care that they are in.
There's another question, where can we obtain a description of all the services? And the answer to that is multifaceted.
Yeah.
Barry, could you?
Yeah, slide 28 and 29 of this presentation have our SPA manual and the 1115, the HCBS services included in those links. And those provide more than just a description. They go into service components, staff requirements, any limitations. So I'd really recommend that you check out those links for that information.
There was another question related to how to access the qualification standards document. Is there a link in those?
Yes, that is also a link in this document. So I would, again, click anything that says HTTP, and you should be able to get a lot of information on what we're talking about today.
So another question has come in, how can we go ahead with the 2 SPA services when it's linked to the 1115 waiver approval? And that's a very, very valid question. So we are moving forward with the 2 SPA services. I mentioned that we're meeting with CMS next week. Obtaining federal approval doesn't necessarily mean that we're moving towards immediate implementation. You are correct. The implementation of the 6 SPA services as well as the HCBS benefit services are completely linked. And so we're trying to obtain the federal approvals in a sequential order, but we'll move towards implementation as the unified process. Another question has come in, when will the 1115 waiver services roll out? And Caitlin from DOH?
Yep, kind of same scenario there. We're waiting to see how the federal administration, what type of direction we get from federal administration, and we're moving forward as quickly as we can. That being said, and looking to roll out in conjunction with the state plan services.
There's another question. It says, so if non-Medicaid kids meet LOC and LON, they can receive HCBS services. So that is consistent with how it is today. So kids who are non-Medicaid can access HCBS waiver services through the Family of One pathway, which we described earlier. So that will continue on in the future. And children who are non-Medicaid but have the functional criteria that meets level of care, level of need, will be able to, through the determination of their eligibility, their Medicaid eligibility as well, access HCBS services in the future as well.
There's another question. Can you explain what is meant by if they are excluded from managed care, the services will be provided by a state designated entity? I think there's a couple of questions within that. So if a child is excluded from managed care, the services will be available, simply billed on a fee-for-service basis. The state designated entity is the independent entity that's going to help us with the eligibility process for individuals who are otherwise not Medicaid eligible. And so further details on the state designated independent entity will be forthcoming.
Read the question.
Another question came through. My staff are currently not trained to work with medically fragile children or children with a developmental disability. Meredith, do you want to?
Do I have to work with those populations? And the answer is no. On the SPA or HCBS provider designation application, providers will be able to identify the populations that they are qualified to work with. This is we want providers to work with the populations that they are qualified to work with. So if you have no staff that are trained to work with those people, or you don't have experience working with certain populations, but you do have experience working with others, you can certainly outline that on your application. So there's no expectation that you would be required to serve additional populations that you don't have experience or history or trained staff to work with, no.
Great. There are multiple questions coming in requesting clarification around the state designated independent entity. And we are still having those conversations at the state level between DOH, OMH, OASIS, and OCFS. And further information will be forthcoming on that.
This is Brenda. I don't know if you can hear me now.
Go ahead, Brenda. So,
okay.
Brenda, you're going to clarify the member months turning into number of children.
Yes. Yes. Why don't I can do a couple of the financial questions. To convert from member months to eligibles, the average length of stay for children that are listed in member months in the waiver and in the contract is 10 months. So if you divide the member months by 10, you get the rough number of eligibles you're talking about. So for example, roughly there are 77,000 member months in calendar year 2014 in HCBS, and that converts to about 7,700 children in HCBS. And keep in mind that of those 77,000 member months, about 28,000 of them are already enrolled in managed care but receive their HCBS services fee for service. Another financial question that you all had asked is about medical loss ratios. There was a question about, will there be a medical loss ratio for the children like there are for the adults? And at this point in time, there is not going to be a medical loss ratio exactly like the adults because the adults had a HARP line of business. However, the new Medicaid managed care regulations require an overall medical loss ratio for all populations, and so that is one of the things that New York is exploring. A third financial question that you all had was, can you explain the concept of non-risk on page 34 of the application, the 1115, and the concept of going to full risk in 2 years? And at this point in time, for the next 2 years, the health plans will be enrolling providers and paying providers for the services rendered using the government set fee schedule. The providers will be paid the fee schedule, and the health plans will be reimbursed at the fee schedule for any claims that pass through. So neither providers nor the MCOs will be at risk. Are there any other financial questions you all want me to take care of?
Brenda, could you clarify whether you meant to say all Medicaid-funded services or simply the HCBS services in your last statement?
Yes, the HCBS services will be non-risk for providers and for MCOs. Thank you, Mimi.
Thank you, Brenda. Very, very helpful. We have a couple of other questions that Shelley's going to help us out with.
Sure, right. So like Brenda just said, we got a question, are the HCBS services in the managed care capitation or through fee-for-service Medicaid for 2 years as it is for adults? So the HCBS services are not going to be included in the managed care premium for at least the first 2 years. There's going to be a pass-through payment through the state, so it's outside of the capitation, as Brenda just stated.
It's also known as non-risk.
Right, non-risk, same thing.
And it is anticipated that after 2 years, those services, HCBS services, will go into the capitation rate. There's a question about what happens to the rates after the 2-year government rate. At that point in time, you tend to negotiate those with the MCOs.
Right, and I'll say that there are certain government rates that are required in statute, and I think potentially some of them beyond 2 years. So clinic rates are some of those rates. Okay, so there's a question, is it likely the April 1 application deadline will be postponed? So as it was stated earlier, this isn't a hard deadline. This is when we're going to start, taking a look at the applications that come in and work towards designating providers. It's a rolling deadline. So if you're not ready to submit by April 1, you can still submit after April 1. There's a question, have SPA services been approved or are they still in draft form? So no, they have not been approved by CMS. The state submitted the 6 new state plan services for approval to CMS. I think it was December or early January, late December. And we are still awaiting CMS approval. As folks know, there was a large shift in the federal administration, so there's a lot of waiting and seeing and taking the temperature of how things are going federally to know what's going to happen going forward. But we're still committed to moving forward, as Caitlin said. We're moving everything along.
There is a question that says, I know you can fill out a Medicaid application concurrently with the designation application, but the Medicaid application says you need the designation letter and the designation application says you need a Medicaid number. Please advise. Thank you for that question. So yes, I think that you have identified a kink in the works. So this is a great question. I really appreciate you bringing it up. So what we were really trying to facilitate ease of process and be cognizant of our timelines. And we had thought that we could have providers complete those materials concurrently. In reality, you actually have to have, as you've outlined, a designation letter. You have to have some sort of verification from a state agency that you've been authorized to provide the services before that Medicaid can process your provider enrollment application. This is so that they can assign you the appropriate services to your designation so that they know what you're authorized to provide. So without the authorization of what to provide, they can't put it on the enrollment. So that is correct. So we are going to actually modify the online application to facilitate the submission of provider, SPA, and HCBS applications for those providers who may not be enrolled in Medicaid. And so we're going to make that change so that providers can submit the applications that they've planned, and then once designation has been issued, you can then facilitate your Medicaid provider enrollment application. We apologize for the confusion.
That's great clarification. Another question is, within a family, can you have children identified as level of care, LOC, and level of need, LON? And the answer to that is absolutely yes. HCBS eligibility is child-specific, and it's based, as we've talked earlier, on risk factors, targeting criteria, and functional impairment. And so you can have multiple children in a family at various levels of HCBS acuity.
There are a couple of med-frag questions that I can address. One of them is the 1115 mentions that an assessment tool determining LOC for medically fragile population will be completed by a state-designated, will be completed for that population. And the question is will the CANS New York be used for the level of care assessment tool for the medically fragile population, or will another tool be used? At this point in time, the CANS New York will be used. It is anticipated, though, that it is a potential, there is a potential other tool that could be used in the future as other tools come online, but at this point in time, the CANS New York is the tool that will be used for the medically fragile. The other question was, what are the practitioners included in the other licensed practitioner definition? And they are licensed psychoanalyst, licensed clinical social worker, licensed marriage and family therapist, licensed mental health counselor, and licensed master social worker. In addition to that, psychiatrists, advanced registered nurse practitioners, and psychologists are also included, but in a different authority. So all of those are considered to be licensed practitioners.
Thanks, Brenda. We're also receiving multiple comments around the complex trauma, the health home complex trauma definition and process. We would encourage you to send those comments directly to the health home website so that we can take that under consideration. In the same vein, someone is asking, is there mention of a transition rate for the current 1915C waivers as we move into the managed care environment? So I think you all know that the OMH waiver, the B2H waivers, and the care at home waivers are currently on extension, and we are all at various levels of discussing those renewals with CMS. And as soon as we have something that we can share, and this is Mimi from OCFS, but I'm speaking for both OMH and care at home, that information will get out to you as quickly as we can. We certainly understand the angst that living in transition is causing you, and trying to get that clarity with CMS so we can be clear to you.
We received a question, will the provision that the child can use their existing out-of-network providers for up to 24 months include independently enrolled private duty nurses? So this provision relates to several categories of providers: OMH licensed and OASIS certified providers, so that's providers of clinical services and other types of behavioral health services. It also will apply to services that are being rolled in under the new rubric of the SPA and HCBS services. So, for example, if someone's in a waiver service prior to that service moving into managed care, that person will be able to continue seeing that waiver provider if they're designated provider of the new HCBS or SPA service for up to 24 months.
Thanks, Shelley. Another question, do children have to be enrolled in a health home to be determined eligible for HCBS services? And the answer to that is no. Health home eligibility is separate and distinct from HCBS eligibility. A child who is determined HCBS eligible and not health home eligible, though, will receive the same level of health home care management.
There was a question, so for families excluded from managed care, or children excluded from managed care who also opt out of health home care management, who will provide the care coordination? Their state will be designated an independent entity to provide care coordination for fee-for-service children who are not in managed care.
There is a question on CFCO services, and there is a website on CFCO that has extensive information specifically about CFCO services. They are state plan services, and for children, some of them are already in the capitated managed care plan, like personal care, and they're already under EPSDT. So you have to be very careful about CFCO because they are, in addition to what the children are already eligible for, which is one of the reasons why it's only open to level of care children.
And this is Shelley, just to add something quickly on CFCO. There is a lot of concurrent work being done to develop this benefit and to move it into Medicaid managed care through the State Department of Health with input from OMH, OPWDD, other agencies that oversee providers that might provide services to people that are eligible for this. And there's a stakeholder work group. There's been a lot of stakeholder input, and I think this group is continuing to meet pretty regularly, and information about that is on the DOH website.
Getting a couple of questions around what happens at the end of the 2 years regarding risk. At the end of 2 years, clearly we will, New York State will be monitoring the money flow throughout the 2 years. And we'll be making decisions about what should happen at the end of 2 years regarding risk. Shelley, do you want to add anything to that?
I think, like I said, there may be statutory language related to certain government rates for certain, I would say at least OMH and OASIS services. And right now it's going to be in for 24 months government rates. I also want to address, there was a question about licensed behavioral health practitioner benefit and what practitioners are included in that benefit. That is a new benefit that is available to people that are enrolled in Medicaid managed care right now, adults or children, and it's essentially off-site clinic, off-site Article 31 clinic. So if there's an Article 31 licensed clinic, they can have a practitioner that's providing services or their staff that's providing services in the clinic right now, go off-site and provide those services in the community. We have guidance on the OMH website about this, this benefit. It's up there right now, and we're actually going to be publishing some additional frequently asked questions that we've been getting from providers to get that information out to the field.
There's a question, is the 1115 application the same as the HCBS application that came out in December and that I've already done? So just to be clear, and I apologize for the confusion, when we say an 1115 waiver application, it's actually the state's application to CMS for this redesign and these services. What you're asked to do is really just the SPA and HCBS provider application, which is to authorize you to be able to provide the services. So when we refer to the 1115 application, that's our job. That's what the state had to do to submit the request to CMS for this new service array and these new design elements. Hope that helps.
Someone else asked a question. Oh, I can't see it now. It's hard to read. It's very hard to read.
That question.
Does the non-Medicaid provider change mean that the independent licensed mental health practitioners who are not currently Medicaid providers can be designated? And we just want to reinforce that the SPA and HCBS designation process is applicable to agencies. We do not expect individual practitioners to apply for designation for any of the SPA or HCBS services, nor is it the state's intent to designate individual practitioners. It is only our intent to designate provider agencies who will then employ independent practitioners.
We received a question about if there's going to be help for agencies engaging with MCOs on contract negotiations and rate negotiations and other pieces. And we're going to be rolling out, and have already started to roll out, a pretty comprehensive technical assistance training and education program through MCTAC. I don't know if at the end of this presentation MCTAC folks want to talk a little bit about it, but we had a pretty comprehensive and still ongoing training and technical assistance program for the behavioral health, for the transition of behavioral health services to managed care that's geared towards providers of behavioral health services, many of which had never engaged with managed care plans, some of which had never billed Medicaid before. So we're planning on doing a similar rollout for providers through MCTAC to help support folks as we enter a new world. Yeah.
Here's another question. It's a multi-question question. There are no explicit descriptions of UM/medical necessity practices. Will they require MCOs to follow the CANs or allow other criteria? So there, in one single question, there's several layers there. Medical necessity really only applies to the SPA services, the state plan services. The CANs is being used to do two things. One, it's used to determine health home acuity, and it also will be used to determine HCBS functionality. So again, just to be clear, medical necessity is used to determine SPA access. CANs is used to determine health home acuity and will be used to determine HCBS functional acuity. The medical necessity criteria as it relates to the SPA services, I believe, has been posted. Is it part of our manual? It's yet to be posted. I believe we're still gathering input from the state agency medical directors as well as some of the medical directors of the plans before that gets posted. So stay tuned. Shelley, I'll need your help on this one. By what standards can the MCOs deny care? And then what is our resources?
Yeah, so it's a really important question. So we are also in the process of developing utilization management criteria for these services, and those criteria are developed in conjunction with the plan clinical leadership as well as providers and provider groups in the field. So we're in the process of developing that, so more to come. There was another question that I saw about when we're talking about government rates for 24 months, when does that date start? So it starts on the date of the carve-in of the services. So right now we're scheduled for the carve-in to begin October 1 in New York City, Long Island, and Westchester, although as we've talked about previously, given the new federal administration and the climate, although we're still going forward, that's the date that we're aiming for right now. So if that ends up being the date, then the 24 months will start on that date for those geographic areas. Then if there's another geographic area where the services are coming in later on, the 24-month date will start on that date.
Going back up, under OLT, can independent mental health practitioners be designated? And again, just to clarify, we are talking about only designating agencies, agencies that are licensed, approved, designated, or otherwise authorized by OCFS, DOH, OMH, or OASS will be designated. We will not be designating individuals.
There's a question of, can you please clarify what evidence-based practice a bachelor's level worker might be trained in to be eligible to provide all facets of CPST? In the manuals that are on the website that Barry had pointed out, there is a description at the very end of the state plan manual of the evidence-based practices protocol. And there is a listing of evidence-based practices that I believe there are 7 or 8 that the state is expecting that providers in the state already are providing. And 2 examples where bachelors have been trained and I believe are on your list would be MST and FFT. And Meredith, if you had something to add on that.
No, thank you, Brenda. I think that's great to reference folks to those resources so they can peruse them and look themselves. We provided a wide array of options, so it probably is applicable in a couple different areas. Thank you.
There's a question about how this 1115 intersects with OPWDD eligibility. And at this point in time, the 1115 is written so that if you are eligible under an OPWDD waiver, you will not be included in this 1115 amendment. And so the OPWDD system is completely separate from the 1115. Now, for children in foster care who would otherwise be eligible under OPWDD and have been found to be eligible, those children in foster care then would get their services through this program because OPWDD does not serve them. But at this point in time, there is no intersection. There's also another question asking about the obstacles preventing or delaying the approval for the 1115 waiver. And 1115s are typically extremely contextual as to what is going on in the environment around a state and the nation. And what's going on now with the 1115 is just there's a lot of uncertainty at the state and federal level about the future of health care. There was another question about what happens under a block grant. And at this point in time, it's just unknown. What would happen under a block grant, what would happen under the current environment that healthcare is operating in. And so the obstacle preventing or delaying approval is just this unknown. Secretary Price was only confirmed at the federal level just a few weeks ago, and so it takes a little bit of time for a new administration to find their feet and to look at large programs such as we're talking about.
Thanks, Brenda. I think, as conversations with CMS progress, we'll simply do our best to keep everybody informed in terms of what, issues, obstacles, successes we experience. But thank you for that insight. So at this point, we're feeling as if we've gone through as many questions and provided you with as many answers as we can at this time. We absolutely appreciate all of you who've spent the afternoon with us. We will continue to review the questions that we haven't been able to answer. A lot of the questions I want to reinforce that have come in, I think you'll find answers, if not in the 1115 waiver amendment that's been posted, but in other documents that have been posted, whether we're talking about the HCBS manual or the SPA manual. We are doing our absolute best to provide you with as much insight into our thinking and the direction that we're moving in, absent federal approval. but we are trying our due diligence to keep you fully informed. And so at this point, I think we're going to turn the ball over, if that's the appropriate phraseology. Is it a ball we're turning over? To MCTAC and ask you to wrap it up for us.
Great, yeah, of course. Thanks so much, Mimi, and to the great presenters and folks who chimed in left and right on the great Q&A session. So just to wrap things up, as a reminder, we've received a number of questions, so we'll be taking those back and looking to integrate those into future offerings and making sure that we address as much as we can in the coming weeks. And just as a reminder, the slides and sooner recording are now available on the CTAC website, ctacny.org. You can look under upcoming events. There's a great calendar feature, and you can click on this event, and the resources will be posted there. So thank you again to the presenters, and without anything else, we'll be sure to send around the links as well to folks. In terms of the next, I just saw a question that came through. Is it possible to send a link to where the Q&As get posted? So as I stall for an additional 30 seconds, I'm hoping my colleague Caitlin can just copy that into the comment box one more time. We'll absolutely, in addition, be adding the links to the resources in the weekly TAC digest that comes out on Monday mornings. So stay tuned for that, and thanks everyone so much for participating.